So I'd like to introduce our first speaker. Our first speaker is Mr. Goodfriend. He is the artificial intelligence principal data scientist at Anthem Blue Cross Blue Shield of Illinois, where he develops digital and telemedicine solutions. He has published over 30 studies in applied mathematics and computer science, and with half of these studies in modeling for infectious diseases. He is a researcher at the University of Illinois School of Public Health at Loyola and Loyola University Chicago Medical Center. Sasha holds a PhD in applied mathematics from Cornell and enjoys philosophy and raising my 9th grandson. Sasha, your turn.
Thank you very much. Thank you for the honor of representing to your unit. Can you guys hear me? Can you gentlemen, ladies hear me very well? Perfect. Like I said, it's an honor. I never had such an honor to actually speaking to people who are literally on the front lines of public health, front lines of medicine, treating patients, helping the state, the country deal with this pandemic. I don't have an experience like that. I've never treated patients. I've never really been on the front lines. So please filter what I say through the lens of your experience and through your minds. What I can tell you about is models. What can models tell us and what they cannot. Let me start with a very important and motivating story. This is a snapshot from an important paper that came out from Imperial College London at the end of March. Here on the left, this paper was published on March 26th, and this was a model that attempted to predict the impact of the COVID outbreak on the world. What they're showing here are the predicted deaths per 1,000 of the population in different countries. The low-income countries, the low-middle-income countries, upper-middle-income, and the high-income countries. You can also see here the effect of interventions. So red means no interventions, and then more aggressive interventions are shown in the other bars. You can see here that high-income countries like us would be one of the most affected regions of the world, probably because of the elder population structure. This model was predicting that on the about a year horizon, we would experience 4 deaths per 1,000 of the population, even if significant mitigation measures are implemented, 4 per 1,000. So this number here, this model was one of the most important models for driving the subsequent public response in the UK and in fact the wider world. I think it drove home from a very credible source that this is going to be a big outbreak. So was this model correct? And I think you know the answer. The model was flawed. This was a bad prediction. This is the data that we have as of from Johns Hopkins University, the official reported figures for June 14. And you can see here the actual mortality, the official figures, at least for mortality, which are fairly reliable for developed countries. So for example, in the UK, they experience approximately 60 deaths per 100,000 population. Here in the US, we experience 35 deaths per 100,000 population. So these are two different scales, but if we map this scale to this scale, we were supposed to have 400 deaths per 100,000 population instead of 35. So this model over-predicted mortality by a factor of 10. And this is a significant, to put it mildly, a significant overshoot. This problem, this mismatch is really the biggest topic I would like to address. When can we trust models and when we cannot? Any comments, any questions so far? So, please. Okay, so let me talk about what went wrong. So, possible sources of error. First of all, simplified methodology. The model that was used by Imperial College is what we call stochastic SEIR model, stochastic susceptible and exposed infectious recovered model. I will talk about this type of modeling down the road, but this is one possible source of error. Second source of error is inaccurate basic medical data. There are not the rate of asymptomatic cases, the rate of mortality, other issues could have affected the model predictions. The model was also driven to some extent by unreliable data from China. The fourth issue might have been what you might call, or I might call, scaring away the wolf. The model has driven the policymakers to action. It has driven the public to action, and it might have sort of kept the wolf at bay. It might have, in fact, caused so much of a change, so much of an effect that the pandemic did not happen. In which case, you know, that this is a degree of indication to this work because you know, a pandemic is something that you can stop. It's not an earthquake. It's something that if you are sufficiently proactive, you can stop people from dying, and it might have had this effect. So in some sense, it's like in Jonah when you know, Jonah warns Nineveh that their city is going to be destroyed, and then the people of Nineveh pray, and they're not. You know, the city is saved. So that's something that might have happened here. And lastly, but not least, you know, one might say that the epidemic is still ongoing, and it's too early to tell how many people will eventually succumb to this menace. So that's the fifth issue here. I would like to argue that it was really a case of a simplified methodology as the primary reason this model failed. And it is not necessarily a condemnation of the model, but something that we all need to be aware of. And this is really my message of this talk, is to look closely as to the methodology being used and whether the methodology is appropriate for forecasting or it is useful for something else, but not forecasting. And I would like to argue that models are quite useful for many things, but forecasting is one of the most difficult things to use a model for. So here's what I would like to talk about. So I'd like to tell you a little bit about the different types of mathematical models, which can be trusted and what they could be trusted to do. I will also tell you about a model that I would like you to trust. And this is a model that I developed with a student, Adam Burns. And this is a model that looks at control of COVID-19 in schools. So it's a very specific type of situation. and we're going to take a look at the CDC recommended policy. Then I'll talk to you about a question that I think is the most, one of the biggest questions in a lot of people's mind, which is, will we have a second wave? Yeah, so I'll show you the latest data and the kind of considerations or analysis without the model. This is a project I've done with my student Anjani, and it has some of the considerations that should be taken into account, and a little bit of a guess as to how things might look through the end of the year. Lastly, I will talk about telemedicine, and this is really a one slide. I really cannot, unfortunately, I cannot officially speak for Anthem, but I will tell you a little bit of some of the trends we are seeing in the industry and some of the exciting trends that are seeing in the industry. So this is the outline of my talk. So let's go back to types of mathematical models. You've probably seen different model forecasts, and what people are quoting, model forecasts are constantly being in the news. So what are the different types of mathematical models, and which types of models could be trusted with what kinds of missions? So what is first, maybe before I go there, I would like to talk about what are the goals of building a model, and what is a model in general. So a model is a computational representation of the real world. It's a tool that allows us to represent the real world and see in a kind of a little petri dish as to what might happen. Sometimes people call this in silico analysis as opposed to in vivo analysis, or kind of in vitro type of analysis that's done in medicine. We have this analysis in silicon, in computational analysis of the real world, and most known is the use of a model to make forecasts. However, models are actually in some sense, much more useful for other reasons. And these are, A, to help us think about the underlying theory, to generate insights, and to test hypotheses. I think that this is something that's less familiar to people if they're not mathematicians, but for us in the math and computer science, this A, B, and C are the bread and butter. And I think that this is something that's been successful time and again. So let's take an example. One of the most important predictions from models is what is known the herd immunity effect. The herd immunity effect is a prediction of a very simple SEIR type model. It is not an attempt to make a forecast. It's simply the prediction that an outbreak will stop even when less than 100% of the population becomes infected. You might think that in order for disease to stop, you would need to have everybody infected. But a very simple model actually shows otherwise. It shows that you might need to have a lot less than the 100% of the population infected, and you will get the outbreak to stop. So in general, when you build a model, you talk to the doctors, you talk to the public health people, and you try to kind of summarize the knowledge, that's the theory behind how an epidemic happens, how a specific epidemic transmits, how long does it take for a person to recover, what is the probability of mortality, and all of those little things are put into a very simple representation, which we call the model. And then we use this very simple tool to then make interesting insights. And those insights are sort of popping out from the model, even if you have a fairly simple representation, it sort of pops out, those insights just kind of pop out. That does not mean that the model could be used to make a forecast. So that is the point where things can start break. Because in order to make a forecast, you have to capture everything. It's not enough to just get a few bits and pieces and start generating insights. In order to make a forecast, you have to really capture everything about the disease. You have to capture everything about society, the political reality, the medical reality. This is very, very hard to do. So forecasts are hard, but insights are much easier to do. So before I go to the next part, which is talking about the different types of models, does anybody have any questions or any issues they want to bring up? All good? Yeah. Okay. So the first type of models is what I call non-mechanistic models. So non-mechanistic models are models that lack an internal representation of the phenomenon. So these models, there are many varieties of these models. One of the models is, for example, time series extrapolation. There are models that use machine learning or deep learning to make a forecast. These are models that are fairly easy to build, and they're very versatile. So here's a data set that shows something like a stock market trend. You can see maybe daily values of a stock, and then at a certain point, we run the model and we make a forecast. So this model is some kind of an attempt to extrapolate from the data. The model looks at the data before and extrapolates into the future. It does not have a representation of anything like the stock market. It does not have a representation of traders making transactions. It does not have a representation of the economy. It just looks at the data points right here and makes an extrapolation into the future. The problem with these models is the following. Since the model does not have internal structure, it is unconstrained. So it does not know when the reality changes. So if you have a model of the stock market, it will not tell you that it will not be able to make a forecast for things like the stock market shutting down because of a terrorist attack, or the stock market is shutting down because of some kind of a policy decision. This is something that the model has no ability to predict. And in a more subtle way, their underlying reality could change in ways that are not less dramatic, but still very important. And a similar thing, of course, applies to infectious diseases. If there is a gradual change in, for example, how people respond to infectious disease, if they start wearing face masks, then the data that you captured before is not really representative or useful going forward, because the underlying system has changed, and this type of model does not have that underlying representation. So what do you do in infectious diseases? Well, we can start with building the simplest type of model of an infectious disease, and this is known as the SEIR model. So the SEIR model is a model that does have this internal representation. It has the representation of the disease states that a person goes through. Most of the population starts susceptible to a disease, and then it goes to a stage which is known as exposed. Then they become infectious themselves and ultimately recover. There are many variations of this model. You might divide the population of recovered into people who are recovered but resistant to reinfection versus people who recover but then become susceptible again. So some people could become vaccinated and so forth. So this is just the basis of this model, and it could be varied. So notice that the disease states are represented here. But the model, of course, is quite simplified. What it ignores is in the individual variation, the geography, transmission, behavior. So in this model, all the people who are susceptible, millions and millions, are represented by a single variable. the number of susceptible. And unfortunately, this is the kind of model that Imperial College published and distributed to policymakers. We know that not every person is the same. At the very least, we have different age groups. There are many people with different immunological states. There are people who live in group housing versus living in individual housing. There are people who take public transportation to work versus people who don't. And so it's so SEIR models quickly become too simplified to capture all of these things. However, these are still very much a useful model, and this is the type of model that gives us the prediction of the herd immunity that is actually confirmed by more sophisticated and detailed models. The Rolls Royce of the models, kind of the F-22, the big canon of models, is something called agent-based models or individual based models. They're not called, we prefer to call them agent-based models because the acronym is ABM. If you call them individual-based models, the acronym becomes IBM, which is not exactly what you mean. So they're called agent-based models. Why? Because in this model, every single person is represented. You represent where this person is, where they live, where do they commute to work sometimes. You represent infrastructure, schools, workplaces. You can directly represent specific disease control measures, such as people wearing face masks, or you can say maybe people who are age 18 and higher wear face masks. People who are young don't wear face masks. So this is something that you can actually represent in this model. You cannot represent in models that are less sophisticated. These models, unfortunately, have their own weaknesses, and they are not ultimately able to capture all of reality. So some of the weaknesses of this models are the following. We know what people do in normal life, but we don't know how they will act in new circumstances or emergencies. Secondly, they are reliant on large databases, such as the census. But those large databases tend to be more superficial. Now, the more you know, the wider your data, and the less deep is the data. So that's a problem. And of course, there's uneven coverage of special population, like say nursing homes. Not every data set will have nursing homes. And of course, that's a huge problem for a disease that disproportionately affects the elderly. So that's a problem. Nevertheless, these models are certainly a substantial advance over other generations of models, and I would argue that these models could be more relied on when you're looking at forecasting. I think certainly the CDC uses these types of models for their kind of planning. But ultimately, of course, I would like to highlight the following thing. And if infectious diseases needs to be informed by numerous factors that no human, not even a team of humans, can fully capture. There is the biology, virology, immunology, and physiology issues. There is the psychology of it, travel pattern, medical behavior, and so forth. The sociology, the social structure, social behavior, networks, the political science, the local, state, and federal agencies, and how they relate to each other, what kind of policy measures they could implement or not, whether the policy measures will be adhered by the population or not. The healthcare system, medical economics, incentive structure, medical innovations, which are very difficult to forecast. And the list goes on. And of course, ultimately, there is the unpredictable randomness, the butterfly effect that could make everything change from forecast. So all of these is ultimately a very big barrier to accurate forecasting of epidemics. I think that there are models now that are increasingly realistic, but I mean, it does not mean that they could be fully trusted. I mean, I'm told that, you know, for weather forecasting, you know, it maybe 50 years ago or 60 years ago, weather forecasts could be barely relied on for next day forecast. Well, now, you know, in the current generation of weather forecasting models, you can rely on, you know, maybe for weather forecasts for a few days out, but you might not rely on them for something that will happen in a week's time. So this is where computational epidemiology is. I think that it has made some progress, but it is not omniscient by any means. So here are my kind of bottom lines, if you will. I think that there is clearly a line that should be drawn around simple models. I think simple models are useful for generating insights, but they're not to be used for forecasting. I would, you know, the mathematicians like to argue that models are generally better than guessing, but I don't think that they can really be. You simply, you know, sometimes it's better to guess than to sort of take a model. I think that well-designed models, such as agent-based models, could be used for forecasting, but even them have limitations. When the model is dealing with an unprecedented infection or policy, that is something that's very challenging for a model to do. I think you can rely on models to predict something like influenza, but when you're talking about a disease that we have not really seen before, that's a problem. There's issues with data quality. For example, if you don't know, for example, the true state of a disease because of low testing rate, then the data is very challenging to work with and really poorly accounted for. And new population settings. So, you know, can we take a model from Illinois and apply it to Indiana? Or can we take a model that was built in Italy and apply it to Indiana? Probably with a bigger and bigger grain of salt. So oftentimes, a better way of doing planning is to use heuristic experience and trial and error. Before I go to the next part, would anybody like to bring a question or anything I can speak about? Thank you. Okay. Should I continue then? Can you guys still hear me? Thank you. So now I would like to present to you an evaluation that I did with my student Adam Burns. And this is a study that might be relevant to some of you about a CDC policy for symptom-based isolation. This is a paper that's available on medRxiv, and it's going through peer review right now. So what I'm showing you is not peer reviewed. So the CDC influenza guidelines includes the following guideline. Encourage students, parents, staff to take everyday preventive action to stop the spread of germs. Teach students, parents, and staff the importance of staying at home when sick until at least 24 hours after they no longer have fever or signs of fever without the use of fever-reducing medicine. So the idea in this guideline is that people who have influenza have a certain risk of infecting others, and this risk continues even after the person no longer has fever themselves. So they can come, if they feel fine, they feel the fever is gone, and they're sent back to school or to their workplace, they might still be infectious. And we want to prevent that thing from spreading. So, what the CDC says is that those people, students, should stay at home for another day after their last fever. So this type of a guideline is not exclusive to to influenza. And I think that one of the interesting angles that we wanted to look at was also to look at COVID. Could we do something like that for COVID as well? So the CDC does not, as far as I know, talk about fever and COVID. Right, as far as I know, the guideline now is to stay in isolation for 2 weeks. But 2 weeks is a fairly long time. It could be very disruptive for people to be isolated for it is very disruptive. And at some point we might decide that we need to develop more nuanced guidelines for isolating people, even with COVID. So how long should people stay isolated with COVID, and how long should people stay isolated with influenza? I'm gonna now use a model to evaluate the CDC policy for influenza and then speculate as to what might be the right number for COVID. The tool that I'm gonna use is an SEIR model. Of course, this is, as you know, and is a simplified model. So this is how this model is gonna work. All the students in the school are divided into about a dozen different types. So there are people who are susceptible, and they're divided into, say, 6 different cohorts, which correspond to different age groups and grades. And out of these cohorts, some are vaccinated. So some of them are sort of out of the picture. We are not assuming that the vaccine is perfect. The vaccine might be leaky and only have, say, efficacy of 50% or so of cases. So students in the school can be either isolated or unisolated. So if they're isolated, it means that they're staying home. If they're unisolated, it means that they go back to school. Meanwhile, they're also progressing through different stages of the disease. For influenza, we looked at 9 stages of the disease, and every stage they have a certain level of infectivity and also a certain level of symptoms. So in the first stage, they have low infectivity and low amount of symptoms. But as they progress on day 2, 3, and 4 for influenza, they become highly symptomatic and also quite infectious. But then their symptom rate declines. In parallel, the students are going back from school and from home. And in the model, we use certain rules to determine whether at a different disease stage they will prefer to be isolated or prefer to go to school. So some of this behavior has been captured, but not in a particular realism. This is not an agent-based model, so every box actually looks at all the students in a particular grade who are in a particular stage of the disease. So that's a model that we built. Then we checked that the model has some validity by looking at an actual outbreak. So we looked at 3 different outbreaks. I'm going to show you one of them. So this is an outbreak in South England of the pandemic H1N1 influenza that happened from May 9, 2009 through June 2nd, 2009. So the real data is here in this dashed line, and this is you can see the number of students who showed up with influenza-like symptoms, and the red line is our model. So the model has been calibrated; all the parameters have been tuned to match the outbreak. I would say not all the parameters. We had 6 parameters which were tuned. There are many parameters in the model that were driven by data, so they are not tuned. You can see that the model at least has ability to match the data to some extent, not perfectly. So this is some kind of a calibration exercise. So now let us see what the model predicts about this CDC policy. So in this graph, I'm showing you a hypothetical outbreak with different policy measures. And I think that this shows you one of the powers of mathematical models is that I can sort of do an experiment without doing an experiment. I can simulate an outbreak with different types of policies and then and then we'll see what happens. So if we don't have the CDC policy, this influenza outbreak will follow this type of trend. Yeah, and I'm assuming that a single infectious student arrives to school on January 1st. So this is how the outbreak will happen. You can see these little spikes and then troughs. This happens because of weekends and school closures, like a spring break. So if we bring in the CDC policy, the model predicts a substantial decline in the number of students that are going to be becoming infected. Notice that it does not spread out the outbreak. It really literally but it lowers the peak of the outbreak substantially. The outbreak still goes on until about May. One interesting thing that we found is that if you increase the isolation to 2 days, then the outbreak significantly weakens. And you can see here that you really go down by a lot if you go to 2 days. So this is something that we did not expect. If this is true, then maybe there is value for keeping the kids for 1 extra day. You might even say additional days of isolation could be helpful, but clearly a lot less so than having just going to 2 days. We then did this experiment with COVID. Data on COVID is less well known. Not that we really know how to that much about influenza, but certainly a lot more than about COVID. So with COVID, the picture is different. Notice that adding a day of isolation after last period of fever has an effect, but the effect is not very dramatic, and the effect is even less significant when you go into 2 days of isolation. So for COVID, there's a less marginal effect, and this has to do with the symptom progression of COVID. COVID is a disease that lasts over a couple of, a person is infectious over a longer period of time, and so keeping them isolated for an extra day has a less of an effect. However, it does not seem to be like the case that that having 2 weeks of isolation makes much sense. So we recommend, again, this is a preliminary result on limited data. We think that 6 days might be a good amount of time to keep people isolated after the last episode of fever. So it's all driven by the symptoms now. 6 days seems to be the right number. So that's all I have about outbreaks in schools. Does anybody want to have a question or right now, or do you want to? Is there anything I could clarify about this model?
Yeah.
Please.
We have to stop here, so I'm going to ask anyone if they want any questions. Okay. Can you summarize basically, the findings in terms of what we can expect in terms of a second wave, just in layman's terms?
Yes. So, this is the work that I recently started with a student, and I with a student, we looked at trying to understand, all the factors that may, that may make us think that there's going to be a second wave versus not a second wave. So let me first of all show you one slide, which is the current data. This is the U.S. overall situation. Again, from Johns Hopkins, you can see here that we are in a period of gradual decline. Potentially something else going on here in the last week, but we are past the peak. But very much in the case of we are still in this first wave of an outbreak. There is historical evidence about second wave. So this is not a hypothetical scenario. So this is, for example, data from the 1918 case. There was a clear second wave that happened, which was a very severe outbreak that happened in the later part of 1918. This is more data from Europe, and you can see here certain countries. In certain countries, there was a single wave. In other countries, there was no first wave, and then the big second wave that happened. So it is very much the case that second wave is not uncommon. In fact, it's quite common historically for influenza. So here's the case for successful controlled versus failed control. By failed control, I mean that we will not be able to prevent something like the second wave. Well, successful control. So why do we think that we are basically winning the war here? We have increasing preparedness, tools, experience, and resources to deal with this outbreak. We have a societal learning to control infection. That's very important. You know, the general public wears masks now. There are studies that suggest that this alone might be sufficient to bring this R0 below the outbreak threshold. There's also progress in vaccine research. We don't know if it's going to pan out, but if we are lucky, we might start getting vaccines even this year. And of course, last but not least, we have a growing population immunity that is slowing the outbreak. On the failed control side, we know that antibody levels are still very low. In certain jurisdictions, only 2% of the population show antibodies to COVID. Others, it goes up to about 20%. But these numbers appear to be too low to achieve a true herd immunity. Return to lockdown is seen as non-feasible. So likely our ability to keep people isolated, the general population quarantine, is limited. The onset of colder weather and maybe viral mutations might promote transmission. We should expect to have spillover from other parts of the world which have poor epidemic control and basically uncontrolled outbreaks happening in parts of the world. And we have plenty of examples of failed control. As you know, for example, China now is in the midst of a resurgence in Beijing. Countries like Singapore, South Korea, at some point have apparently succeeded in controlling, only to experience a resurgence. So what is my guess? If you ask for my guess, we are going to see sustained transmission through the end of the year and possibly beyond. I think that this is, the current data looks kind of like this. So what do we expect to see happening? We expect to continuing to see falling incidence because of growing population immunity, but we are also going to experience spikes, and those spikes will occur because of so-called hyper-spreading events, when there is a big venue or somebody goes to a wedding and 100 people get infected. This is going to show us spikes because the overall the epidemic is slowing down. However, there are clear improvements in treatment which will reduce the case fatality ratio. So this is the picture that I'm guessing might happen towards the end of the year. And then at some point, we will have a vaccine, or we will reach a herd immunity threshold, in which case the epidemic will simply fall off a cliff and disappear.
Thank you so much. Thank you for.
Thank you.
Thank you. We'll take a 10-minute break. Everyone is invited to take off their jackets to dry from the heat. Thank you. So there's cold water over here. We'll meet here at 10 o'clock. 11 o'clock. What is it, 10 o'clock?
It's